Hello, everyone, and welcome to today's broadcast, the Washington State Department of Health's Prescription Monitoring Program, Ensuring Safe Prescribing. It is presented by Garrety, the Operations Manager for the Prescription Monitoring Program at the Washington State Department of Health. I am Judy O'Rourke of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone this event is interactive. We encourage you to participate by submitting as many questions as you want anytime you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears on the screen. Our speaker will respond to your questions via email. If you have any trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Garrety. I will now turn the presentation over to him.
Thank you very much. Hello, my name is Garrety. I'm the Operations Manager for the Prescription Monitoring Program at the Washington State Department of Health. We also call the Prescription Monitoring Program Prescription Review, kind of our brand name. I'm going to talk to you today a little bit about where the Prescription Monitoring Program fits in to ensure safe prescribing. I think part of that really focuses on the beginnings of that story, really focuses on the prescription drug abuse epidemic and our current status there. This first slide shows that we've had a little bit of moderate success bringing prescribing rates down since about 2008, both in Washington and nationally. Reducing opioid prescriptions is part and parcel of ensuring safe prescribing, or safe prescribing is measured a little bit by bringing those prescribing rates down, which were quite elevated. Here we're looking at overdose death rates by drug type for Washington State years 2000 through 2017, and we've broken this down with between all drugs with the darker bar at the top, all opioids with the orange line just under that, and then we can see some of that effect that we've been having on the prescription drug abuse epidemic in that teal-colored bar, where our prescription opioid overdose death rate has really been falling since after about 2010. However, that's also somewhat counterbalanced by an increase in overdose death attributable to heroin, which is the next line down, the yellow. And then we started also tracking overdose death rate by synthetic opioids at the red bar, and very concerned about the upswing that we've seen since 2015 in synthetic opioid overdose deaths. Additionally, we can look at our hospitalization overdose rate, and again, broken down by drug types, top bar in the orange for all opioids, the middle bar in blue for non-heroin opioids, and the bottom for heroin, where again we see an upswing since about 2010, and some fall off with non-heroin opioids since about 2010 also. We often talk about hospitalizations and overdose rates, rates of death when we're talking about opioids and the opioid epidemic. However, these aren't the only costs to our public health system. Right here, we can see that those deaths are really just kind of the peak of the pyramid, and there's a whole lot more depth to the cost of this epidemic across our public health system. When we look at overdose hospitalizations, there were quite a few more hospitalizations as there were compared to deaths for this year. This data is from 2014. We had 695 deaths. We had over 1,500 opioid overdose hospitalizations, and that trickles down again into opioid substance abuse treatment admissions, where we had over 13,000 in our state. And then again, another measure, persons 12 years or older who use prescription opioids non-medically, over 250,000 non-medical users of opioids. So this really has deeper impacts, far more reaching impacts than what we often concentrate on, which is death or maybe even hospitalization rate. This is also an epidemic that affects our most vulnerable. And we see this in the rate of NAS, or neonatal abstinence syndrome. These are babies born already suffering the effects of opioid withdrawal from the opioid use of their mothers. So we can see that the rate of neonatal abstinence syndrome has been on the rise since as far back as this tracks, with 727 reported in 2016. And even with all of these measures and all of this focus on the epidemic, it's hard to believe that still 1 in 4 teens believe there's little or no risk in using prescription pain relievers without a prescription. So now I want to provide you a little bit of information about the prescription monitoring program and its utility. The Department of Health in Washington developed the prescription monitoring program really with an overarching goal of preventing prescription drug overdose. Goals that the department had at the time this was developed was to give practitioners an additional tool that provided more information for making patient care decisions and provide that data which can help providers recognize patterns of misuse and addiction, ensuring that they were able to take advantage of SBIRT opportunities. For those of you who aren't aware, SBIRT is a SAMHSA tool, and it is screening, brief intervention, and referral to treatment. SAMHSA, of course, has got training guidelines on their website for SBIRT. Definitely useful. The department also wanted to make sure that those in need of scheduled prescription drugs were able to receive them, create a useful tool that didn't create additional barriers to patients who had legitimate need. Data from this program can be used to educate the population on dangers of misusing prescription drugs, and all of this combined can curb the illicit use of prescription drugs. Now, the way the system works, dispensers, mainly pharmacies in our state, are required under statute to report their dispensing of controlled substances into the state PMP, which is a repository of that information. That information is then made available to pharmacists and prescribers for patient query access. Information is also made available to law enforcement and licensing entities who can access the system for bona fide investigations involving a specific individual. Our rates for registration right now, pharmacists are around 36%, and that's really one of the highest rates in our state. All of our prescribers, among all of our Washington licensed prescribers, our registration rate is about 20% for direct porthole query access. We do have some cases where some dispensers are not required to report data, and I'll run through these real quickly. Licensed wholesalers, distributors, and manufacturers are not required to report to the system. Anything that's prescribed for less than 24 hours or is directly administered by a provider is not required to be reported to the system. Prescriptions provided to patients receiving inpatient care at hospitals are not required. Pharmacies operated by the Department of Corrections giving care to incarcerated individuals, except in the case where an offender might be released with a dispensing intended for greater than 24 hours of use. Of course, federally operated facilities don't have to follow along with state laws. However, Veterans Affairs and IHS have been reporting to the Washington PMP voluntarily since 2015. And opioid treatment programs are prohibited from reporting their dispensings under 42 CFR. So a little bit of history. Legislation for the program was passed first in 2007, RCW 70.225 in Washington. In 2010, in October, federal funding was obtained for implementation. 2011, in July, rules were adopted and DOH contracted with an application service provider for data collection and reporting. Then in October, an additional federal award was obtained to finalize implementation, and data collection began. Our pharmacies started inputting data to the system. That following January in 2012, Query Access Providers was opened on the live system. And in 2013, there was finally some sustainable funds in House Bill 1565, which provided ongoing funding through the Medicaid fraud penalty account here in Washington. And there was also a proviso with that funding for integration with EDI, that's the Emergency Department Information Exchange here in Washington. So access to this information has grown in some ways. Our original legislation provided PMP access for prescribers and dispensers for patient care, licensing boards for investigations, individuals regarding prescriptions dispensed to them, to EDI regarding that proviso for integration of PMP information into the Emergency Department Information Exchange reports received in the Emergency Department. Access for, of course, the Department of Health and the vendor in regard to program operation. Law enforcement and prosecutors for bona fide investigations regarding a specific individual. Also for medical examiner and coroner for determining cause of death. For the Healthcare Authority for their Medicaid operations, and for L&I Labor and Industries here in Washington for workers' comps claims, as well as Department of Corrections for information on their offenders or incarcerated individuals. We also had access to be able to provide de-identified information to researchers and educators. So over the years, different legislation has added additional access to PMP information. In 2015, Senate Bill 5720 provided that staff of a medical testing lab could access the system for verifying prescription drug use in accordance with the urinalysis testing. House Bill 2730 in 2016 provided access for healthcare facilities and clinics when using a certified EHR connection to the state's Health Information Exchange. Also provided access for legend drug prescribers. At this point, no longer was access limited to only those who held a DEA license for prescribing controlled substances, but this access says any prescriber in the state of Washington can access the system to follow up on their patient care and pull down a PMP history report for their patients. Delegate access for DOH licensed pharmacy staff was also added under this legislation. In 2017, Engross Substitute House Bill 1427 added additional access for the Emergency Department Information Exchange to be able to provide overdose notifications to recent prescribers found on the PMP. Also added access for the Washington State Hospital Association Quality Improvement Program for healthcare facilities and provider groups of 5 or more, that they may be able to obtain a PMP report, data report they can use for quality and improvement and interventions within their facilities. I also provided access for federal and tribal healthcare facilities using their EHR to connect to the Washington State HIE, mirroring what had been done in House Bill 2730. Just a little bit of a hole, a little bit of a gap was left there, not calling out access for federal and tribal healthcare facilities. So it's important to note that House Bill 2730 provided additional access for healthcare facilities when connecting through their, using their electronic health record systems to connect to the HIE. This allows easier integrations at the healthcare facility level. It also reduces the onus, reduces the need for providers to register for an individual PMP account. That registration and access through the portal has been is somewhat of an onerous process, But when the facility, the result of this legislation is that the facility then has the authority to create the transaction, the query to the PMP, and import information directly to the EHR system where it can be presented to the provider directly in their workflow without them having to access a separate portal of any sort. So keeping them in their workflow when they're already looking at medications and already within the flow to make the decisions that need to be made about prescribing. So a little bit of information about what we see with PMP use and its impact, and we can start discussing a little bit on the level of what kind of registration, what's the level of registration amongst our prescribers, our providers in the state. First off, we've got the numbers on the slide show. We've got just over 4,500 accounts for pharmacists, active accounts for pharmacy delegates, prescribers at just over 9,000 accounts, and prescriber delegates at just about 4,500 accounts. In Washington, we've got a total number of DEA registrants. These are providers who hold active DEA credentials and can actively prescribe controlled substances at almost 44,000 when this number was taken at the end of September. When we compare that, when we do the math between that number and the number of prescriber accounts that we have on the PMP, we see that only about 21% of our state prescribers, our active state prescribers, have an active PMP account where they can actually go and look at the controlled substance history for the patients whom they're considering to write a controlled substance for. When we look at this across a slightly different measure, and that is the total number of DOH licensed personnel who have the ability to prescribe in Washington, we again can see that we have just about 15% of our licensed healthcare providers who would have the ability to prescribe have got active PMP credentials. Again, pharmacists do pretty well and have about a 36% registration rate on the PMP. In order to ease access for providers and pharmacists, we allow for delegate use. This means a provider or a pharmacist can delegate the authority to pull PMP reports for patients to one of their ancillary staff in the pharmacy. That might be a pharmacy technician or assistant in a medical setting. That might be a nurse. It might be a medical assistant. It might be a phlebotomist. On the PMP system, we've got nearly 7,000 delegate accounts that are active and ready to be selected by prescribers so they can delegate that access to their ancillary staff. So knowing that the PMP has been registration and access to the PMP through a separate portal has been a little bit onerous, we've engaged in a ease of use project looking at the PMP portal and ways that we might improve access to it. One of the first things we did is we identified and defined some unintentional issues caused at the healthcare facility level with some suggestions for intervention. So these are things like healthcare facilities not providing access to individual private email accounts. These private email can be used for the adaptive authentication challenge that happens through our security gateway, also known as Secure Access Washington or SAW. If a provider can't access an email sent by SAW that has a token for them to then gain access to the system, they are essentially locked out. What we found in some facilities, this was a little a step further than they had looked into providing access. That many times healthcare providers were provided access to SAW for sign-in, but then when it came to the authentication process that had to happen, they needed access to maybe their private email accounts, which were restricted at the facility level. So our document that we presented here, which is available at the website www.doh.wa.gov/PMP ease of use, draws out, really highlights some of these unintended issues that were blocking individual providers from taking part and being able to access the PMP fully from their workplace. We also improved the track for registration, for login, and access to information from the web. We defined this into a single source, a single track for accessing these utilities from the PMP webpage. That's www.doh.wa.gov/PMP. And from that page, you have access for login, for registration, for all of the information that you need for PMP, and it is really kind of our one-stop shop for any access to or any information that you need regarding the PMP. We also added an option for adaptive authentication challenge via text. Actually, this was our partner SAW, again, our security gateway, Secure Access Washington, added the text option for adaptive authentication, which really helped for providers that were in maybe larger facilities where they didn't have a good cellular signal for receiving email or phone call for that adaptive authentication challenge, which was used to authenticate them and allow them access to the PMP. Now that challenge could be sent through text message. They could better receive it, reply to it, and gain access to the PMP. Our partner, Secure Access Washington, also upgraded their user interface. Many of these upgrades were very nuanced. They seem like very minor, very small upgrades, but they had a really big effect on the success of our users registering for the PMP. Something as simple as breaking a string field down for name into two blocks, one for first name, one for last name, made it much easier for the system to authenticate our users and ensure that they had a successful process at registering for access to the PMP. Here at the Department of Health, we've increased our staffing for the DOH PMP Helpdesk. We've had a number of new staff come on board, and this is really in line with the new legislation under House Bill 1427 and the mandates that are coming out over the next couple of months and what we expect to see in increases in registration rates. We wanted to make sure that we were staffed up and ready to handle the influx of new providers registering. We've also increased hours at our PMP Helpdesk for this block of time, for this period where we've got these new mandates coming on board and we know that there's going to be increased provider registration. We've increased hours from 6 a.m. to 6 p.m. currently. This data is really about how frequently the PMP is being used. And what we've got here is the gray bars are showing us the level of controlled substance prescribing in Washington, which has stayed fairly steady at right around 12 million prescriptions a year. It's slightly under that. We've seen some moderate fall off in the past couple of years. Now, we might see a little greater fall off if we were to adjust for tramadol, which wasn't scheduled until 2014. So that adds almost another 750,000 prescriptions a year to our number here. If we were to adjust that out for the years after 2014, we'd see a little greater fall. The teal bars, the tricolored teal bars, are showing our rates of access to the PMP, the number of queries that are created or facilitated by the PMP. The lower portion of that, the orange and darker colors, are showing query access directly through our portal. And it goes from almost immeasurable in our first full year, 2012, to being more significant through 2017 and 2018. But what's really important is that upper part of the bar, that lighter teal color, that's showing the number of queries facilitated via our automated exchange over the State Health Information Exchange. That's automated queries responding right back and being integrated into electronic healthcare record systems. So this quote was really an early indicator of the importance of that integration and automation. Right. This quote came from an EDI user, a clinician in the emergency department, when we first adopted an integrated model with the EDI system. Just as creating a PMP was a game changer, pushing that information without provider bias, without burdensome hurdles, now pretty much mandates providers be aware of these patients' special needs and risks. Now that automation, this is what it looks like to be integrated with a system like EDI or with an electronic healthcare record system. What happens at the hospital level, the hospital uses its connection to the State Health Information Exchange to submit a query from the electronic healthcare record system to the PMP. One Health Board, the State Health Information Exchange, recognizes that as a query for the PMP rather than the other data systems that it services and passes it on. The PMP is able to respond to the query with information for the particular patient and pass that back through the State Health Information Exchange back to the hospital where it's populated into the EHR record. So, however, this isn't just a one-to-one transaction. This isn't a health record system, an EHR system, getting access to only PMP data. It really looks a little more like this, where with only one connection between the hospital, the pharmacy, or the provider office to the State Health Information Exchange, they have access to 5 different data sets of the Department of Health, as well as the labor of industries for labor and industry reporting, as well as connection to the health authority for access to the clinical data repository. So it really reduces the overhead of the end user, the hospital, the provider, clinic, or the pharmacy, and having to facilitate only one connection where they would have had to maintain as many as 7 different connections to separate programs. So when will Washington PMP users be able to access information, PMP data from other states? Well, it's something that we've got our eye on. It's something that we're moving towards. What we have is a situation. Washington has laws and rules that allow for interstate data sharing. We have access to we allow access for Washington PMP users and for users in other states to access the Washington PMP and pull reports directly from our PMP systems. We've piloted Washington data, integrating Washington PMP data into the EDI system in Oregon. So this is a interstate model of interstate data sharing via the Emergency Department Information Exchange directly from the Washington system into 5 pilot programs within Oregon in the Portland area, being able to ingest PMP data for people presenting with a Washington address. Okay. Currently, there are 2 national data sharing hubs. This is really getting into what are our next steps? What's coming down the pike with the ability for Washington users to be able to log on to one system and pull reports from many different states. There are 2 national data sharing hubs. Washington has executed an MOU, an agreement for, and is moving towards implementing connectivity with the RX Check Hub, which is growing in leaps and bounds. We expect shortly to be able to transact data with a number of different states. Sadly, this doesn't right now doesn't include our most important neighboring states, Idaho and Oregon, who are on another data sharing hub. Washington is in a place right now where the MOU for connection to that hub hasn't been okayed by our Department of Health legal And at this time, we don't have an ETA for development of that connection. We continue to work on this MOU and the language that's at odds, and we hope to be able to facilitate a connection and interstate data sharing across the second hub as well. So with all of that, what should providers be taking away from all of this? Number one, keep an eye on what the data is that you're getting. Data is important. Sometimes patient history on the PMP isn't always accurate. There are things that can be done to improve it. Got to remember that the record genesis really happens back at the provider office when the provider is writing a prescription. This may be the sole opportunity to interface with the patient and check an available form of ID for the legal format of the name. And one has to remember that the patient many times does not present at the pharmacy, and therefore there'd be no opportunity to check that sort of identification at the pharmacy. If the pharmacy receives good information from the provider, good data from the provider along with the prescription, this is the information that the pharmacy is going to input into the PMP, and ultimately the information that the provider is going to have access to when they pull down a PMP report on their patient. In instances where providers receive inaccurate or incomplete data from the PMP, we do have a process for reporting that back to the PMP where we can get it, where it's documented, and where we can follow up on it and ensure that corrections are made so that we can improve the data that's available to providers. That process is available from our website, www.doh.wa.gov/PMP. Once providers have taken a look at the data on the PMP, what should the effect be on their prescribing? Well, that's up to the provider's interpretation. But the information that's out there, the guidelines for prescribing laid out by the agency medical directors group, says that safe and effective prescribing really is all about providing the lowest effective dose for the shortest therapeutic duration. We also want to remember that patients need to be prepared to take the quickest and most responsible route for disposal of these medications when left sitting around in the medicine cabinet may be enticing to somebody who might want to use the substance illicitly. It also creates a danger for small children getting into medicine and easily ODing on these kind of medications. We also want to be able to inform patients about the need for safe storage so that these medications can't be inappropriately accessed. So the PMP should help providers check for instances of misuse or multiple prescribers. It should help check for drug interactions, especially the instances where opioids are prescribed along with benzodiazepines. This is kind of a 1-2 whammy for patients, and those sort of interactions need to be really considered, and information needs to be provided to the patients that there's a large potential danger there. You can use the reports for compliance with treatment contracts if you're a provider providing care under a treatment contract. PMP reports, of course, help you keep an eye on what your patients are doing with regard to controlled substances. It allows providers to check history of transactions linked with their own DEA number. As a provider, you can access the system and you can look up the history associated with your DEA number to see if there are any errant prescriptions or any prescriptions there. Certainly there have been instances where a prescription pad has been stolen, and there's a number of fraudulent prescriptions out there. So additionally, for providers, keep in mind that checking the PMP is made easiest when you use our power of delegation. If your access is through the direct query portal, if you have to access the portal, the web portal to do your queries, delegate to your ancillary staff. If they're licensed by the Department of Health, they can register an account, and you as a prescriber can select them for delegate access. They can then pull those reports on your behalf so that you don't have to. Certainly make sure that you train your staff so that they know how to use the PMP. Use a champion in the staff, somebody who maybe pulls these reports on a regular basis, can train other staff as they're coming on and help them through the registration process. Certainly provide prescribers and ancillary staff register for the PMP in exactly the same way, so that PMP champion is going to be able to help anybody in the office, anybody in the group register for a PMP account. Make sure you retain documentation by placing a copy in the patient file or ingesting into your EHR system. Integrate your EHR system to directly access and query the PMP. Automation is key. When we automate this connection, the provider then the information becomes pushed in front of the provider rather than the provider having to go through extra steps to pull the information from the system. And when it's pushed in front of the provider within their workflow, it almost guarantees the provider is going to have access to it, is going to view it, and is going to have to consider it when considering to prescribe controlled substances. Now, when the PMP report provides information back to the provider that raises some alarm bells, what happens? Many times we get calls at the department where providers are put off. They're frustrated with the patient. What we say is, don't fire the patient. The patient is still in need of medical care one way or the other. This is a great opportunity to talk with the patient, to coordinate care with the other providers listed on the report. Consider using a patient treatment agreement, whether that's yourself as a provider being the primary care provider for the patient, or if you reach out and coordinate with a primary care provider to suggest that they enter into a treatment agreement with the patient. Verify the prescriptions listed match your records. If you've been prescribing to the patient, go through those and make sure that they are all accurate. If they're not accurate, report it back to the PMP program where we can follow up and ensure the corrections to the data on the system. Refer your patient to treatment or other specialty care as needed or as warranted. And educate patients. Take the time to educate them on the dangers and risks of overdose with these medications. So a few resources that we have available here in Washington. Number one, the Washington Agency Medical Directors Group. The AMDG first published guidelines back in 2007. They've been updated a few times since, with the most recent update coming out in 2015. The AMDG really lays out guidelines for prescribing opioids for pain in Washington. UW Telepain. It's a wonderful resource. It's a teleconference where pain specialists at the UW participate every Wednesday from 12 to 1:30. And what they do is they take those difficult cases that providers might have, consider them, and provide feedback on proper care for the patients. A very quick resource is takebackyourmeds.org. This provides a list, provides a geographical interface, a map with all of the available areas, all of the available locations where patients can take their medications for safe disposal. StopOverdose.org, which is put up by the Alcohol and Drug Abuse Institute at the UW, and provides a lot of information regarding overdose education, naloxone, anything you might need access to and information for someone that you're concerned about using or misusing opioid medications. Now I've got a few slides to go through to show you what the registration process is like and what it's really like to pull a report on the PMP. So registration, we have a how to register for access video available from YouTube. This is all of this information is available from our website at www.doh.wa.gov/PMP. So again, a little more information about our ease of use project and our ease of use website, our webpage. This is really a project where we've tried to refine the access to the PMP query portal to make it easier and quicker for providers or their delegates to access the system and pull patient reports. Right here is our one-stop shop for registering for and getting access to the PMP to pull those patient query reports, available at www.doh.wa.gov/PMP. And right at the top, we've got buttons for provider login on down the page, or to the right there's a button for information on how to register. First step in registration is setting up a SAW account. SAW, of course, has access or has a help button with the SAW interface right here for registering your SAW account. Once you've registered your SAW account, you'll request the PMP service from a menu list within SAW. What you'll need to register, you'll really need about 10 minutes or so. You know, it's not just signing up for a Gmail account. There's a bit more security with it. SAW will go through a security authentication process with you. It will take more than 2 or 3 minutes. Okay, you'll need a computer with internet access. You'll need an active Washington DOH issued healthcare credential. And if at all possible, have your driver's license in your hand. Right? We want to make sure that you're using legal format of your name and a registered mailing address. You'll need 1 or 2 active email addresses that only you have access to. These need to be confidential email addresses, and these will be used by the SAW system for authentication process. It'll send you at times when it needs to challenge to verify or authenticate. It'll send an email that you'll need to access and retrieve a numeric token from. You'll also need 1 or 2 phone numbers for this. Those phone numbers need to be ones that you can answer directly, like a cell phone. Certainly not one that rings in the front office and would have to be transferred. Something like that doesn't work for the authentication process. You'll need the service code for PMP. This is actually, through our ease of use process, no longer necessary. You can pick the PMP service for provider access from a menu list within SAW. You'll need your DEA number, if that applies, and also your full Social Security number. So, pulling a patient query. Again, we have videos on this process. It's fairly simple. Once you're on the PMP system, this is the view that you have. You'll go to Query and Recipient Query. You'll have to check off the attestation before you're allowed access to the interface for inputting the patient's last name, first name, date of birth. There's a few options within the query system that you can choose to broaden your search based on date of birth, or first name begins with and last name sounds like. There's also an option on the patient query system for you to pull queries for more than one patient at a time. When that returns, you'll get a pick list of different identities that closely match the parameters of your search. So you can imagine if you're searching for John Smith, you might have quite a number of John Smiths to go through, and using your control key, select the ones that you're with high certainty are your patient. The system will then provide a report back, an HTML format that looks like this. You can choose to export to a PDF and print. You can also choose to map the results. The system will provide a map showing the locations of patient residents, providers, and dispensers. And of course, the report shows the date prescribed, the date filled, the drug name and quantity, as well as prescriber and dispenser contact information. Delegate management on the system is also an easy process, and I want to remind you that delegates are available for prescribers, right? Prescribers would be master accounts on the systems, and delegates would be ancillary staff that they can delegate authority for patient query to. How does a provider do that? by accessing the system, going to user management, and under delegate accounts, as you can see on the screen, the prescriber can then select from the alphabetical list of delegates all of the delegates that they wish to be attached to. A prescriber can have many delegates. A delegate can be associated with many prescribers. It is incumbent upon the delegate then to ensure that they're appropriately pulling patient reports for the appropriate prescriber for the patient. And lastly, we have a number of resources available directly from within the PMP, links to useful resources at SAMHSA, here at the Department of Health, to the AMDG, that's the Agency Medical Directors Group, as well as the CDC prescribing guidelines. That concludes my presentation.
Thank you, Gary, for that informative presentation. We will now start the Q&A portion of the webinar, and we'll address some of the most commonly asked questions by our viewers. If you have any questions you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. Our speaker will respond to your questions via email. Let's get started. First question is, how did the changes made by House Bill 2730 improve access to the prescription monitoring program in Washington?
Right. So 2730 provided the authority for a facility operating an EHR system to access the PMP and submit and receive back a patient query report. What this did is by putting this authority in the hands of the facility, it says that providers in that facility that would have access to that PMP information through the EHR system no longer have to necessarily register for or maintain an active PMP account. It really reduces the overhead for the providers. The providers are able to log into their EHR system, which contains all manner of HIPAA-compliant information in the first place, and while they're within their workflow for the patient, the EHR system can make that query and pull back the PMP information for the provider. So the provider has to perform no additional actions to have access to the information.
Thank you. When will Washington Prescription Monitoring Program users be able to access PMP data from other states?
That's a great question. It's something that we're currently working on right now. We've just recently executed a memorandum of understanding with one of the national hubs that we hope to be connected to. Our vendor tells us we'll be connected to at the beginning of December 2018. This will allow us to exchange data with a whole lot of states. Sadly, it doesn't take into account, our two neighboring states, Idaho and Oregon, are not active at this time on this hub. They're active on another national hub, and wouldn't you know it, this is a situation where the two hubs don't talk well to each other. So as we become active in December, we're not going to be able to exchange data with our closest neighbors. We really want to. We're still pursuing a connection with that second hub. We hope to iron out some issues that our legal department has had with the agreement to join that second hub. We hope to move forward and create that connection. But for the time being, come December, we should be active on the RX Check hub. We should be able to exchange data with a great number of states, and we're really excited that we're seeing more and more states access or join that RX Check hub as well.
Thank you. Looks like we have time for one more question. Patient prescription history on the prescription monitoring program isn't always accurate. How can it be improved?
Certainly, and again, a great question. You're right, prescription history isn't always accurate on the PMP, and it's important to keep in mind where we're getting that information from. That information is reported directly from dispensers, right? Those are the pharmacies that are filling and providing the prescriptions, not always to the hand of the patient. In many cases, these patients are in pain and they don't present at the pharmacy. So the ability to check an ID for legal format of name doesn't go real far at the pharmacy. Many times that information is coming directly from the prescriber's office where that prescription has been written, and this might be the only place where there's an availability, an opportunity to interface with the patient and check ID for the legal format of the name. Remember, when writing a prescription, that information is going to be handed off to the pharmacy, and that's the information that is going to be reported to the PMP. It is imperative that it be accurate, that it be the legal format of the name, a good and valid address. When you receive information back from the PMP that is incorrect or incomplete, we do have a process of reporting that back to the PMP where we can follow up with the pharmacies to ensure that the information is corrected on the PMP. You can find a path to that process on our webpage, doh.wa.gov/PMP.
Thank you. I would like to once again thank Gary Garrety for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February 15th, 2019. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's event. That is all for now. Thank you for joining us. We hope to see you again soon. Bye.